towards reducing maternal and newborn mortality. I want to begin by thanking our distinguished government representatives for being with us today. Dr. Deo from Nigeria, Governor Wilbur from Kenya, and Matron Margaret Mena from Sierra Leone. Your leadership and your willingness to share your experiences with us are invaluable. As we begin, it's important to remember that behind every statistic is a mother, a newborn, a child, and a family. When we discuss maternal and newborn mortality, we're talking about daughters, sisters, mothers, women who are the backbone of their communities and their economies. We're talking about unfulfilled futures and potentials lost. The progress we've seen gives us hope. Since the year 2000, global maternal mortality has declined by more than a third, and global mortality has been cut in half, child mortality. These gains represent millions of lives saved, families kept whole, and communities strengthened. But the reality is stark. Every 2 minutes, a woman dies from preventable pregnancy or childbirth-related causes. And every day, almost 6,500 newborns die, mostly from preventable conditions. We know that these deaths are concentrated in the countries and the communities facing the greatest resource constraints. But the good news is that solutions exist. Evidence-based, cost-effective interventions can prevent most maternal and newborn deaths. What's needed is sustained political will, strategic investment, strong health systems, and quality care for those who need it most. And today we will hear from leaders who are putting all of those things in place. For more than 50 years, JPIGO has partnered with governments in more than 50 countries. And what we've learned is that sustained maternal, newborn, and child health impact comes from country-led priorities and country-owned solutions. Today, we are learning from 3 countries that are demonstrating that leadership in action. Nigeria, where the MAMI initiative is addressing maternal mortality in 172 local government areas that account for more than half of the country's maternal deaths. Sierra Leone, which declared maternal health a national emergency and has been leading on developing robust quality management systems for maternal, newborn, and child health care. And Kenya, where counties such as Vihiga are showing us what subnational leadership looks like in practice, prioritizing MNCH across planning, budgeting, and service delivery. Each of these contexts is unique and faces distinct challenges, but each also offers lessons that can inform and inspire action elsewhere. Today, we will hear directly from the leaders implementing these efforts to understand what's working and what barriers remain, and explore opportunities for shared learning and collective action. I'm grateful to our panelists for being here today. And with that, I will turn it over to Pearl Nanka-Bruce, who is JPIGO's Ghana Country Director. She's going to moderate the panel. Over to you, Pearl.
And thank you, Alison, for those powerful and grounding remarks. I just want to confirm that you can all see and hear me. All right, I think there's a bit of a lag, and now I'm sure that you can all see me. That's great. Thank you so much, Alison, for those remarks. Your reflections remind us that maternal, newborn, and child health is not only a technical priority, but a very central pillar to a country's resilience, prosperity, and national development. And we have some distinguished panelists today to take us through some very important discussions. It's my privilege to welcome them all. Our first panelist is Dr. Dayo Adeyanju, who is the country lead for MAMI in the SWAP coordination units of the Ministry of Health of Nigeria. Dr. Dayo, you are welcome. Next, we have His Excellency Dr. Wilbur Otichilo, who is the governor of Vihiga County in Kenya. Dr. Wilbur, welcome.
Thank you for allowing me to be on this session.
And next we have Matron Margaret Mana, who is the program manager for the Palliative Management Program in the Directorate of the Reproductive and Child Health in the Ministry of Health and Sanitation of Sierra Leone. Matron Mana, welcome.
Yeah, thank you very much. And it's my pleasure to join this all-important meeting today.
All right. Thank you all for joining us and for your leadership. It is especially meaningful to have a panel that is representing both national and subnational leadership, because as we all know, progress in maternal, newborn, and child health is ultimately won when alignment happens across all levels of the health system. And so we will start with discussing a few initial questions, and then we'll turn it over to our audience for questions. And so to our audience, if you have any questions as we go along, please put them in the chat and we will get to them when we get to that section. And so for our panelists, I will begin with a broad question for all of you. So this question is for all of you. And we will start with Dr. Dayo and continue in that order. When you look at maternal and newborn deaths and stillbirths in your country, what has shifted most in the last 5 years? And also looking ahead to the next 5 years, what shifts will be most critical to accelerate these reductions in mortality and stillbirths, and to enable your countries meet the every woman, every newborn, everywhere targets? Dr. Dayo, we'll start with you.
Thank you very much, Pearl. And I must appreciate you, Go, for inviting us to be here, and tender the apology of Dr. Mutaka, who is unable to join for other critical reason. Thank you so much. So in the last 5 years, in fact, I will extend it to 10 years, to say that for Nigeria, looking at the NDHS, which is the survey that we conduct every 5 years to look at the mortality for maternal as well as the newborn. Clearly, you will see how in the last 10 years we were oscillating, between, in 2008, I start with that, it was 545 for 100,000 live births. Then in 2013, 5 years after, it rose up to 576. And then in 2018, it became 512. So as we journey like that, in the last 5 years, clearly something, was wrong, which was definitely our siloed approach or intervention. The fact that one, we tried to, intervene, getting the midwife, to the facility at another time. We tried to put commodities at another time. We try to say, let's get the community, through using the CHIPS, the Community Health Influential Program. So all of this siloed approach, kept us operating, which informed, moving forward in 2024, in line with the Nigerian Health Sector Strategic, Investment Renewal Initiative, to say that moving forward, we have a clear health sector strategic blueprint, which look at 4 things, 4 pillars. One is to improve governance, defragment. And second is to improve the outcome. And thirdly is encourage local production. And then lastly is health security. But the improving population outcome includes women and children. And then we adopted the sector-wide approach to drive, the process. And this sector-wide approach now, what is new in 2024 was what led to the launching, unveiling of MAMI, which is Maternal and Newborn Mortality Reduction Innovation Initiative, which now looks at all of the different drivers of maternal mortality, from the different delays of seeking, of reaching, of receiving healthcare, taking accountability, and that sector and the coordination. And so now with that lens, we have now come up with the MAMI, with the strategic framework to say you need to engage community at the same time, You need to put in place processes for emergency transportation. You need to also get the facility ready, either at the BMOC or primary health care or at the CMOC, the general hospital, ensure there is a mandatory reporting of every maternal death for us to review and forestall future one. Set up structure right from the ward through to the local government, the state, to coordinate, all of these various interventions, and then put in deploy digital, in all of this to ensure that we now, have a coordinated approach, to integrated approach to now crash mortality. And in 1 year, the result is exciting. We are able to begin to see like 17% drop in the facility, maternal mortality. So basically, that is what is different. That is flipping, looking at the lesson learned in the last 5 years and projecting into 5 years. And our target is in 2028, we will drop maternal mortality by 30%, focusing, clearly on the state that is giving us 55% of the maternal burden. So that's our targeted approach. And that's also one thing that we have done differently moving forward. And so that's basically, the stretch, in the last 5 years or 10 years, and then looking forward to another 5 years. Thank you.
Thank you very much, Dr. Dayo. So what I'm hearing is definitely a sector-wide approach and targeting the areas and the districts that are contributing most to the mortalities. Dr. Wilbur, over to you. Can you tell us how this is happening in Kenya and in your county especially?
Been all group activity service that if some of the facilities have become a little bit not somewhere as a county we is delivering the health facility. It is that we all know the financing, national financing, particularly, it was financing, but now we have to focus on financing. So this is now, as a county, we have now put in place within our budgeting process that every financial year we must budget money for program on maternal and child care programs. So this is one area now we have said that as a county, we must now take into account that. We are also decided now we are mobilizing our domestic partners. So we have gone in and done quite a lot of mobilization of partners. For example, we managed to test one of companies called Faricom Communication, and we are working with them. They have built us a very nice mother, whereby they are able to. So we are on the core partnership. As it regards to,
Thank you.
No, I think I wanted to say that there's
Go ahead.
data is very important. So it is so that we for us to make decisions.
Thank you very much, Dr. Wilbur. I think we are having a problem with your connectivity. So if you could put off your camera, I think that would help with the connection. Yes.
Okay.
But thank you very much for those insights. It's obviously a lot happening, from improving access to also looking at improving the quality of care. And then I think you even answered some of my questions that will be coming up on domestic financing and how you are working on that and looking at domestic mobilization and partnerships. And I'm sure we'll get to hear a bit more on those when we come to that. Matron Mana, can you tell us about Sierra Leone?
Okay, thank you very much. That's really an important question for us, and it resonates with Sierra Leone's situation. So Sierra Leone, one of the biggest shifts that we have had over the last 5 years is really reducing the maternal mortality rate. And that did not happen. There was a lot of investment in terms of human resource production. So what we did was to increase the production of especially midwives and the specialist obstetrician gynecologist. Then we also embarked on task shifting, where mid-level health workers like community health officers were trained for long periods, 3 years, in helping us to do cesarean sections in our district, because what we have was more urban-based specialist care compared to where 75% of our women live. So when we increased the production of midwifery, we established midwifery schools in regional levels. Because when you take a midwife from a district to come to national for midwifery training, once she finishes, she cannot go back. So what we did with support of our partners and the ministry in the front line, we actually decentralized midwifery training institution and also increased the production of tutors. We embarked on the South-South Cooperation, where we used to send our tutors to Ghana and Nigeria in the sub-region. Once they finish, they come back and we deploy them to our midwifery schools. Then we also did task shifting in the production of nurse anesthetists. You know, anesthesia is just offered by doctors, but for us in Sierra Leone, we used midwives and nurses to do anesthesia for at least 2 years. So once they finish, they work under an anesthesiologist and they provide safe anesthetic services for our women. So also what we did was to improve on the infrastructure. So we had to look at expanding our labor suits to make them friendly, and we integrated the experience of care, the RMC, into what services we are providing. However, with all what we did, what we have not been able to do very well was to really look at our perinatal deaths, be it we had more stillbirths and also neonatal deaths. So that's the other focus that we as Sierra Leone we really want to look at. And because we do not have population, recent population-based data to really tell us what's the magnitude. So what we are trying to do now is to put improvement around labor and birth so that we are able to tackle the stillbirth rate and also the neonatal mortality. And the other thing that we as Sierra Leone really want to focus on how to manage postpartum hemorrhage, because our MPDSR data is telling us what is now killing them. And we are moving away from blaming to using it as a learning platform. So that MPDSR, we have tied it now with quality improvement processes. So whenever we review a death, we don't look at blaming who did what. Now we are looking at how can we improve and how do we manage better. So for Sierra Leone, our facility teams, our QI teams, we are also putting them at facilities to help us track quality improvement interventions at that level. Then we are looking also at prioritization of high impact activities. One is the kangaroo mother care. We have established a special baby care unit, and we have a kangaroo mother care space where we are really moving forward to initiate KMC, immediate KMC, intermittent KMC, and also the other one prolonged. And we are tracking the data. The data currently is telling us that we have been able to save 96% of babies that should have died. And this one is not cost intensive. So it's just a motivated and competent health worker and also preparing the parents or caregivers to really support with that. Then also what we are really looking, we don't want to focus on training alone. We are now moving to bedside coaching and also on-site coaching and strengthening supportive supervision, not just policing, but strengthening supportive supervision, then also mentorship of our healthcare workers. Because training them in a classroom setting, we cannot sustain that one. It's more cost intensive. So what we are now doing is to have mentors situated in each hospital to support us with the on-site and very close to the bed mentorship. Then what we really wanted to do now as a country, or what we have done, is to see how respectful, people-centered care as part of the experience of care. Because when you talk of quality, mostly people look at provision of care rather than the experiences that women have. So we really want to see how our facilities are more friendly and people are treated with respect, with dignity. For me as a midwife, we have lived to see it all. Because when you take care of a mother and you end up losing that mother, even emotionally, you go through emotional pains and psychological trauma. So what we are now doing, we want to remove heavy workload for midwives. So we want to encourage them as well to be able to speak out, to talk about events and don't take blame that it's my fault, I did not do that. So those are the few shifts that we did in maternal mortality reduction. And we really had one of the huge decline by 79%, almost to 100%, 79 to 80% of maternal mortality that we are able to reduce. However, like I said, we really want now to focus because our maternal mortality was 1,682 in year 2000 for 100,000 live births, but today we have 354 in 2023, and currently there is huge decline, but we are still waiting on population-based data so that we really ascertain that this is how much we have reduced maternal mortality. However, that figure has been quoted and is evidence. So Sierra Leone, we really focus on maternal mortality reduction. And now we want to focus around the point of care and facility readiness. Because if the woman comes, our MPDSR data is telling us that 95% of the mothers are now dying in facilities. And the 5% is in community. So we can now focus, and we know now what is killing them. For 5 years, we know postpartum hemorrhage is one of the major killers. Eclampsia is the second, and sepsis. So what we want to do now is to ensure our facilities are ready when they come. We want to ensure we have 24-hour service, 7 days a week, and the person is motivated and competent to be able to address those needs. We want to position blood because postpartum hemorrhage is an issue. So now we are doing birth preparedness in antenatal period, where we at least allow relatives to come and donate. We have 2 unit blood that is already packed in the facility. If you have postpartum hemorrhage, we can use. At least we are not going to waste time again to look at screening blood and what have you. Then we also want to ensure that our facilities do immediate triage and also response to emergencies. So we are pre-positioning life-saving commodities in our labor suits now and in our theaters as well. Then, like I said, the enabling environment is what actually government is also taking on board. We don't want to depend on the national power grid. So now we have solar that is also moving our instruments and our machines in theater so that we have 24-hour electricity coverage and also potable water in our institution. However, for the sepsis, we are strengthening IPC services and also ensuring that some of the, what do you call it now? Services are available in terms of accountability. So we are now doing live time tracking. Every Friday, we have MACDEM that we look at least 1 or 2 maternal deaths and also child death. So we want to track. We don't want that long recall period. So every Friday, even the Honorable Minister of Health, the deputies, the Chief Medical Officer, all partners, and we and district leaders, we discuss maternal death. So we can even do it virtually, so you don't have to come to Freetown. You stay in your district and you present what happened in your facilities, and we discuss that one at national level. So we have national quality improvement plans and also the district ones. And we are also encouraging data use culture. So people look at their data. What is their data telling them, for be able to put strategies in place to address the issues that emerge. Thank you very much.
Thank you very much, Matron Mana. There is so much going on in Sierra Leone from what you have shared with us. And I'm glad to have been part of that process, working with you and your team in reducing that phenomenal reduction in maternal mortality over the last few years.
And thank you for your support. We really appreciate and miss you.
Thank you. I think that from the responses that we've seen across the countries is that mortality reduction really is possible and can be accelerated when we look at data, leadership, improvement in the quality, service frontline readiness, and also prioritization of activities from what we've heard from our panelists. We will move on to some country-specific questions, and we'll start with you, Dr. Gaya, for Nigeria. And you mentioned the MAMI initiative, which has been set up to target the local government authorities that are responsible for over half of the maternal deaths. So it's been about 2 years since that was launched. And so looking back in the 2 years since this MAMI initiative was implemented, what pivots are you making, especially now in the current rapidly changing fiscal landscape? Dr. Daya, I think you're muted.
Yeah, I got you clearly, and thank you so much. So clearly, after the unveiling of MAMI, I've told you that we are using the sector-wide approach lens, to crash maternal mortality, meaning that everyone needs to be on board, one plan, the one budget, one report, one conversation, and then one voice. So all of that, is the principle for sector-wide, approach. So we then had to go embark on cooperation workshop, with all the 33 states, where we have the 172 LGAs contributing the 55% of maternal mortality. And so after this, we were able to develop, the MAMI implementation plan. Clearly, we understood the drivers of maternal mortality sitting down with, the state, the local government, the community, with the federal, institution. So we came together, looking at it from that perspective, having their input into the plan, and then set up what we call the MAMI State Task Force to drive the implementation. So clearly, from what I mentioned initially, there are 6 thematic areas for MAMI. We then have to reduce. The first thing that pivoting is reducing what is it that we need as an irreducible minimum to crash maternal mortality. And there are 4 basic things, MVP, which we call the MVP, the minimum viable product. First is that we need to have a community-based health worker. I told you, this community-based health worker help in listing the women, linking them, to facility for ANC, ensuring that they also come and deliver there and have a postnatal care. Secondly is then to also ensure there's a basic and functional ready L2, BMOC or the primary health care. Then the third is to have a clear emergency transportation, and this time around we mean a rural emergency transportation for the women, to in case of emergency, to get them to the next, what we call the CMONC, or the general hospitals, or the specialist hospitals, or the teaching hospitals, as the case may be, and of course to have those teaching hospitals or the general hospital, or the CMONC, empaneled by our national health insurance to have a financial protection for emergency maternal and newborn care. So this 4 is what we regard as the 4 minimum viable product, the MVP, that will ensure, that a woman's life is safe if she's in distress. The community-based health worker would have done what is called the birth plan, the complication readiness, there's the risk stratification, so that if there's going to be an emergency, there's a complication readiness, for that. And then, so after all of this, so each of the states was now graded to see their status of the MVP, the 4 MVPs, and each of the local government also we looked at, such that with our sector-wide approach, we also have what is called the resource pooling. We can then, have a targeted, intervention or support, to the state that, have identified in that plan a gap after everything has gone into the annual operation plan. What are the partners supporting and what is the gap? And with this gap, we are now able to go, as federal, as SWAP sector-wide approach coordination office to support, each of these gaps, using that to provoke, a domestic resource mobilization that can help, in the seamless implementation of MAMI across, all the LGAs. So for us, it is indeed a priority for government, the present administration, led, by President Bola Tinubu, to say that it makes no sense for any woman to die or have a newborn that will not live beyond the age of 5, and also, with the clear leadership of the coordinating minister, Professor Pate, and all of us, working with the state, like I mentioned, local government, and then ensuring that there's implementation. So we now have a clear dashboard where we try to track progress across, the state with indices, indicators that we put together. So we look at this, at our MAMI national coordination, and then interface with the state MAMI task force, and the state task force interface with the World Development Committee, and in that way we are ensuring that if there are issues, we could problem solve, and then we could intervene within a period. So our MAMI coordination meeting happens at least, the irreducible minimum is once a month. And so with that, we are able to see as progress, has been tracked across the 172 LGAs of MAMI and then the 33 states, of MAMI. So this way, we are keeping tab and we are reviewing and then ensuring, that we have a purposeful or targeted, intervention and support of financing, and for us, we also clearly, try to promote, reward for excellence, to ensure that that midwife in the remote facility or remote places have their clear recognition, because as along the year, at the end of the year, we're going to be rewarding performance. So it's all part of the enablers that we have put in place in addition to deploying digital. And of course, for some of the states or local governments that have a lot of demand issue, we are also trying to bring in incentives to get the women to come to the facility and subsequently get tracked, by the community-based, so for us, and of course, to improve the quality of care, we are strong on low dose, high frequency, instituting the safer back bundle of care, and across, all, the LGA, two states, have done that, and that way they are also trying to, they have the impact in 1 year has shown a clear reduction in the stillbirth incarcerated babies, and because of the skills and that ability, to respond, very quickly. And so we also want to begin to deploy this point of care ultrasound, which will ensure that we have a quick risk stratification and ensuring that the women with high, risk, are ready, to go straight to the CMONC without having to wait and the parabolating at the BMONC centers. So all of this, there's a lot of revitalization, there's a lot of distribution of mama kits, which has in it the calibrated drip to measure postpartum memory, knowing fully that postpartum memory is one of the leading causes, and of course we recognize preeclampsia, we know maternal sepsis and all of that. So all of these things are the effort of government. MNCH commodities are priority, they are distributed across now as we speak over 1,000 of this facility in over, over 100 of the Miami LGAs. So resources is not enough, it can never be enough, but the ability to prioritize, and then look at what gives you the greatest impact, is how we are deploying, our resources. And of course, like I mentioned to you, the result is amazing. And we believe we sustain clearly, we definitely will crash mortality, by 2028. But of course, looking forward to meeting the SDG, in 2030. Thank you.
Right. Thank you very much, Dr. Dayo. Looks like definitely on course to crash maternal mortality. And prioritization, as you have said, is key to that. Thank you for the insight. I'm sure other countries can learn from Nigeria. We'll move on to you, Governor. Dr. Wilbur. And this relates to Vihiga County. The Every Woman, Every Newborn, Everywhere Progress reports reflected that its sustainable national focus is critical for national progress and called for investing in subnational targets, plans, budgets, and data. Can you speak to can you tell us how you've done this in Vihiga County? How you are ensuring that maternal newborn child health remains prioritized in your planning and resource allocation? I think you had spoken a little bit about that in your initial comments. Dr. Wilbur, confirm you can hear me.
We are putting a better priority on because as the issue that we are on national, we have national which each one is expected. Then you register that program. You can to so that are
We seem to have lost Governor Dr. Wilbur, so we will move ahead with you, Matron Mana, as we try to get him back. And Matron Mana, having had the privilege to work alongside you and other colleagues in Sierra Leone, I've seen firsthand the country's commitment to quality improvement, even in the most highly constrained settings. Sierra Leone declared maternal health an emergency several years ago and has also been a leader in the global quality of care movement. Based on your experience, what are the most critical system level actions needed to move from high coverage of MNCH services, as you have mentioned in your previous submissions, but moving from there to now consistently high quality of care, particularly in low resource and fragile settings as we have in Sierra Leone? Mr. Mann, I think you're muted. If you could unmute.
Okay. Is it okay now? Thank
Yes.
you. Sorry. Okay. So, like I said, the question actually it goes to the core of Sierra Leonean experience on maternal health. So, what we have learned in the past was high coverage that does not guarantee good outcomes, good maternal and child health outcomes. So the most critical shift that we need now to move from coverage to making quality measured and managed priority. So we just don't want to depend on assumption or intention. So now what we want to see is not how many women came, whether they receive the right care at the right time is where Sierra Leone wants to focus now. That means we need to track quality indicators, not just the process, but quality indicators and especially outcome indicators. So we are not just looking at their numbers now. We are looking at what did they receive and was it the right quality using the health service package. The other second key system action that we actually want to focus on is to institutionalize MPDSI. We want to treat every maternal and perinatal death intervention like not just an event or blame people, but we want to learn from it. How can we now focus on what has killed our mothers over the past years, or what is killing our newborn? For you to see neonatal or birth asphyxia being a highest killer of newborns, it means we have to strengthen intrapartum care and also look at sepsis prevention, because babies coming to the world, if we don't look at what is killing them, it means we are denying them their rights. Then the other thing that we really want is quality should focus on facility readiness now, because like I said this morning, we have learned from the MPDSR tracking and IDSR, including DHIS2, we have realized that 95% of mothers are now dying in our facilities. So coverage is meaningless if we don't respond to emergencies. So we have to ensure that there is access to blood. and we have functional theaters that moves from nominal coverage to just effective coverage. So it's not just coverage, but it has to be effective. Finally, improvement does not happen from top-down policies alone. So facility quality improvement teams supported by continuous mentorship and strong referral system are what turns policy into better care. So we must not forget respectful care for women and newborns, and also people-centered care, because experience of care affects whether the mother seeks services at all. If they are experienced or they are not satisfied about the care, they cannot come. So free healthcare is there that is helping us to mobilize them to facilities today. But when they come, we have to ensure that their experiences are nice. In summary, what I want to say is we have to shift from just counting services to measuring the outcomes, and not just training, but we have to have continuous support system and access to safe, effective, and respectful care that is delivered at every time, not just selected days. So even if you look at our clinics today, they don't have days like initially we used to have Tuesday ANC, but currently at any time you come, we are providing integrated service in a continuum of care. So of course, like I said, the training is not just enough. Training alone cannot. So we have to ensure there's bedside coaching. So we have, like I said this morning, we have mentors now, and we have tied them to mentees. So every young midwife or every young nurse is tied to a mentor. And also from the training institutions, we have preceptors. With the support of our partners and the ministry, we have preceptors now who guide, so that curriculum translates into real action evidence. Initially, people are passing, yes, but what is the competency and what is the skill set, together with the right attitude? So our referral system, of course, you know of the names. The ambulance system is there. So now what we have done also is to get ambulances stationed within hospitals, so that if the names ambulance cannot solve that one, then also that hospital ambulance as well we can depend on. And we have established triage system in all our maternities as a country, and resource centers for our newborn or pediatric hospitals as well.
Thank you, Matron Mana. I'll have to move us on for time, but thank you. A lot of wonderful things happening in Sierra Leone that we can all adapt and learn from. Dr. Wilbur is back, and so we'll see if you are able to, your connection is good, and if you can continue quickly from where you left off, telling us about what pivots that you are making, what you are doing to ensure that MNCH is prioritized in planning. You had mentioned about budgeting and financing and ensuring that all pregnant women are on the national health insurance. Dr. Wilbur,
Yes.
are you able to? Yes, please go ahead.
Thank you. Thank you. I'm back again. I would like to say that one other areas which we are giving priority is in capacity building of the community health promoters. These are people whom are mothers whom we have trained at the local level, and they have the capacity to be able to monitor and give advice to mothers who are pregnant. So we are making every effort at that community level, because most of these mothers stay in those communities. So these health promoters, we are putting a lot of effort to give them capacity. And when the mothers are ready to go to visit a health facility, they are the ones who even give them the alert that it's time for you to go to the hospital for the check. And so this is a very important issue. And also the issue of data is very important. And we have, through various development partners, been able to empower the community health promoters to have gadgets at the local level where they can collect data. And this data is transmitted directly to our central area in the headquarters, where we analyze all the information. So every promoter remits data which goes to the National Archive, but also to the county system. So we are able to monitor what is happening to every mother or every pregnant mother, so that we know exactly what is going on. The other area of interest, which as a government we are putting in, is on area of nutrition. We have set up a very elaborate nutrition directorate, which again does a lot of community empowerment through the community health promoters, where mothers at the local level, they are given basic information on nutrition and what should be done, what type of food the mothers who are pregnant should be able to have or be able to access to. So this ensures that there is a synergy in between from the community up to the headquarters where we have our experts. The other area which we are giving a lot of effort or a lot of priority is ensuring that the commodities that are required for maternal health care are available in our facilities, because that's one of the challenges we have had before, where when the mothers now are ready to get into the health facilities to give birth, sometimes the commodities that are required are not available. So that's one area we are giving a lot of priority. And this we are doing through budgeting, so to ensure that commodities that are required are available through our local budgeting process. So those are some of the areas of interest that we ensure for us to ensure that the available environment is created to ensure that mothers, when they get to the hospital, they are able to be attended to, and so on. And
Thank you.
we also have, sorry.
Thank you, Dr.
We
Wilber.
also,
For time, I will have to move into the next questions. Thank you. And the next questions will be coming to you, so we'll continue from there. But we very, very grateful to you all for those insightful inputs across your countries. We wanted to make sure that we had time for questions from the audience, and we already have one. If there are more, please be sure to put your questions in the chat. But for all of you, we have a question from the audience, and that's one question that countries have been grappling with. So this says, I'd like to know how you all have prioritized integration of services, especially when funding is often siloed into specific disease funding. What strategies have you used to avoid duplication of efforts and fragmented provision of care? Dr. Wilber, if you can take this very briefly from your experience in Vihiga County.
Thank you very much for that question. Duplication is an issue that we have looked at, and what we have done is to ensure that we have an integrated approach on how we deal with these issues of maternal care, and therefore we ensure that we discuss with all the stakeholders or all the departments. For example, the department dealing with the nutrition, department dealing with the let's say public health. We have an integrated approach where we are able to discuss and agree priorities that should be given first line of engagement. Then from there, we are able then to allow people involved to work together so that we allow the duplication of efforts and the resources. So that's what we currently are doing. And also when it comes to resource mobilization, we are ensuring that various partners we are working with, they don't duplicate the same activities in various sectors within this area. So we ensure that we bring most of our development partners be it local or international, together, so that we are able to agree on which priority should be given by which player or which by each of the development partner.
Thank you, Dr. Wolbe. And that we recognize is usually a problem, especially at the subnational level where you have partners coming in and if there's no coordination. So we have a lot to learn from Vihiga County, and I'm happy to hear that it's been very successful. Dr. Dayo, integration. How are we ensuring that it is being successful, especially with the MAMI initiative?
Thank you. I mentioned earlier that the Nigeria Health Sector Strategic Investment Renewal Initiative, has a clear health sector strategic blueprint that has 4 pillars, which all the state, the partners, the local government have to align, in developing their annual operation plan. That's the first. Then secondly is that in line with this sector-wide approach, there's a compact that have been signed between the federal government, the state government, local government, as well as the partners to say we're going to work, together. And I use the word of the minister, if we are not aligning, then you'll be distracting us, from, our focus and our purpose. And so it is in line with it that the MAMI program, has also been co-created between the federal, the state, the local government with the partners, clearly identifying what the federal government is going to support, what the state, what is in the annual operation plan of the state, and then what, is the gap that we are rallying and mobilizing additional resources from the various, private sectors, to support. And there's a clear mapping of who does what where, with the development partner group. So clearly that way there is no room for silos, or there's no room for fragmentation. And then the sector-wide approach also speaks about one budget. There's a resource pooling, and which makes our intervention targeted. Then of course, as I mentioned, one report. There's a joint annual review every year where we sit together to look at how far have we gone in terms of crashing maternal mortality, in terms of indices that relates to RAMCA. And then we speak to it and interface. And this gives us the leverage for one voice and then one conversation. So all of this speaks to how we integrate, our intervention. We also integrate programs. We don't look at, programs in silos again. We are saying for a woman that's come for ANC, she can have intermittent prevention treatment for malaria. She can have HIV screening, and then there is a prevention of mother-to-child transmission. So that purposeful integrated approach is what we are adopting, and I think it's really working, for us in Nigeria. Thank you, and over to you.
Thank you very much, Dr. Dayo. Over to you, Ms. Lomana, very quickly. You're muted.
Okay, thank you very much. Actually, that's a very critical question, especially for resource setting like Sierra Leone. So actually, the key to integrating services while you avoid duplication is alignment and prioritization. So firstly, you have to anchor a single national essential health service package. So Sierra Leone, we have a single health service package that flows from national level to subnational as well as community level, where all partners currently, they are aligning to that same package and prioritization. So that reduces parallel programs or vertical programs and fragmentation. Then also, what we have done is to integrate actually happens at the point of care. So now services, initially you'll come to ANC, then they say HIV services are done by somebody and counseling. So what we are now doing, we deliver multiple services in one visit using the same workforce, the same human resource. Now they all know what to do. Then at the end of the day, it's the same data systems that we are using actually to move that one. Sorry, there is some hitch that I'm having. Programs or vertical programs and fragmentation. Yes. Then also, what we have done is to integrate actually happens at the point of care. So now services initially you come to ANC.
There seems to be a challenge with Michomana.
So what we are now doing, we deliver multiple. There is power cut. Can you hear me, Ben? Using the same workforce, the same human resources. Oh, good.
Yes, I can hear you, Michomana. You got cut off and we're hearing an echo. But I think that we got the import of what you were saying. So alignment at the national level and then all the way down to facility level, ensuring integration of services. We were not able to, thank you, Metromana, and we see that there are some challenges. We have some audience questions, but unfortunately we cannot get to all of them. But this webinar is a part of a series that we will be having to hear about MNCH experiences and priorities. And so there'll be more opportunities for discussions going forward. I'd like to thank all our panelists for this very enriching dialogue. The message really is very clear, and I think we got it all loud and clear, that together through country leadership, which is very essential, strategic partnerships, evidence-informed decisions, we had data all throughout, and also sustained investment, we can accelerate progress in maternal newborn mortality and save lives. Thank you all very much. And with that, I will hand it over to Anita Gibson, a director for the Aligned Secretariat.
Thanks so much. Thank you so much, Pearl, and sincere thanks to our speakers. Despite the power cuts and the bandwidth issues, there was a lot of really important information that came out of that discussion. And so I really appreciated the opportunity to hear about some very practical experiences and perspectives. I think for me, what was outlined at the outset of this conversation was that the objective of the conversation was, we wanted to hear directly from leaders, implementing efforts in support of improved MNCH to really just understand what's working, what are the barriers, explore opportunities for partnership, shared learning, and collective action. So that's what we set out to do at the beginning. I wanted to share with you some of my reflections on what I've heard during this important conversation. I think against the backdrop of a shrinking fiscal space, it seems that increasingly governments, obviously are being asked to do more with less. And what really struck me about today's conversation was we heard a lot about it was work at scale in multiple governance in multiple counties across the country. I think we were able to get a real nice perspective of what's happening specifically in Vihiga County, but I think it also gives us a glimpse into what's happening kind of at the subnational level across the country. I think what struck me was the complexity of the work in which you are all engaged. You're all very systems focused, very data focused, using data to drive decisions. I think I heard all of you use the term problem solving multiple times. I think what that says to us is that they're really, we're beyond the conversations around low hanging fruit, silver bullets. There's a real need to focus on systems level investments. Coordination, we heard a lot about, we heard about integration. And so I think what you heard today from our colleagues in Nigeria, Sierra Leone, Kenya was really how they are really engaged in a lot of coordination and working with multiple stakeholders. I loved hearing about Nigeria's one plan, one sector-wide approach under which everyone must align. I took note of this, no distractions, no distractions from that one plan. That seems to be a very important way of keeping people focused and aligned. I also heard about again, moving to complexity. We're going from siloed to integrated approaches, sector-wide approaches. We're talking about issues of commodities, of transport, of financial protections, all working in coordination with each other. And so I think what I was very struck by was the complexity of the discussion, how data are being used to inform and target priority investments. We've heard about, looking at where are where is the mortality? Where are we having issues? And really focusing some of those investments. I think the other issue, I think reinforcing this notion of complexity is looking from the community to the facility, from subnational to national. Again, it's really encouraging to hear about kind of some of the efforts that are happening kind of across the continuum of care, if you will, and across different levels of care. It actually makes me think about perhaps a future conversation can focus more specifically on coordination and governance. I think all of these countries that we heard from today have very rich country experiences that really require lots of coordination and government of multiple stakeholders. And we got glimpses into it. We heard about joint annual reviews. We heard about budgeting and target setting. I think it would be very interesting, as this is the start of the series, to kind of talk a little bit more about kind of coordination and governance. Maybe just another reflection is I loved hearing about all of the focus on not just coverage and counting, but quality, and all of the different ways in which we are really exploring how we kind of maintain strong quality, both in terms of provision of care as well as experience of care, as well as point of care, at the point of service, really bringing services and needed services to women when and where they need them. And so I think, again, just thinking about future conversations, perhaps in a shrinking fiscal environment, perhaps there's an opportunity for continued sharing around how to be efficient without compromising quality. I think there were just some really important points raised again around using data to really inform kind of the work of quality improvement teams and kind of how quality is addressed while also looking at coverage. So what I appreciated most about today's discussion, I think, is we often see data and trends, but understanding the real work behind the data, you know, the choices that you're making, the partnerships that are producing results, you know, how do different contexts approach shared problems, I think has been really helpful to kind of get some glimpses into that today. And so I'm so pleased to be part of today's event. And I'm still reflecting, for those of you, hopefully many of you in the audience, I know some of our panelists were at the International Maternal and Newborn Health Conference last month, hosted by our kind colleagues in Kenya, and to which Sierra Leone and Nigeria actually sent delegations, along with about 30 other countries. And similar today, a lot of those conversations were amongst people who make policy, deliver care, study health outcomes, and think about all of the consequences of how those decisions come together. And so I just have so appreciated this conversation around the mix of practical experience. You've highlighted some clear kind of technical issues, some technical areas that you've prioritized, and even thinking about kind of the importance of the political commitment. I'm looking at you, Governor Wilbur, is what makes these conversations so important. Real progress really depends on our ability to listen to and harness the different perspectives that we've heard today. And I look forward to continue to learning and sharing to inform practical actions. And personally, how Align and JPIGO can support these conversations. So a really sincere thanks to the organizers, our speakers, and to the audience. Really appreciate it. This was a very productive way for me to start my day here in my time zone. So thanks so much to everyone.